Hello, everyone. Welcome to JACC and JACC Electrophysiology podcast for American Heart Association 2024. It's a rare honor and a privilege for me to have one of our esteemed colleagues, Dr. DJ Lakkireddy, a world authority on left atrial appendage occlusion devices, who is presenting at AHA, and the paper that's appearing in JACC is an important 5-year follow-up of the Amulet study. DJ, welcome.
Thank you, Shep.
And to enable our readers to be able to see this, we have actually put together a couple of slides that would showcase the key parts of the study. So DJ, to kick off, let me first congratulate you on an important study for the field. And as I'm projecting the central illustration, let me kick off by asking you this question. Over the years, you have very carefully given us follow-up studies at various points on this important trial in terms of follow-up. And of course, this is a very important timeline for the follow-up. Could you give our listeners what you think should be important takeaways from this presentation?
So, Shiv, thank you. So this trial basically shows us the performance of the Amulet device, which is a dual closure mechanism device compared to a single closure mechanism device, which is a Watchman 2.5 version. Of course, it's a ester iteration of what is currently available in the market. So it essentially compares the levels of closure and then the relative outcomes at various stages during the follow-up. So a dual seal closure mechanism device obviously has multiple advantages of being able to be more versatile. It has the ability to close appendages that have more proximal lobes and more wider ostia, which oftentimes are difficult to close with a single closure mechanism device. So obviously, as anticipated, we had a significantly higher level of closure rates. That means the peri-device leak issue was significantly lower in patients who were given the Amulet device compared to the Watchman 2.5 version. And this closure rate actually persisted over 1 year, right? That's, I think, one of the most important salient features of the device. And what did that translate into? Did it translate into improved stroke rates or improved bleeding complications? And did it really result in improved overall mortality? So what you find very interesting here is there is a significant class effect in this, where there was absolutely no significant difference in the stroke rates or the major bleeding complications throughout. And that class effect was wonderfully sustained and demonstrated in this 5-year follow-up. What is more exciting in this is the number of fatal or disabling strokes through 5 years were significantly lower in the Amulet arm. And the number of DRTs or PDLs that were preceding these strokes or cardiovascular deaths were also significantly lower. So what I believe happened here is these gains in all-cause mortality or the fatal disabling strokes are probably related to the fact that the Amulet device provides a better closure and decreased peri-device leak issue, which in turn means you have less number of fatal strokes and maybe you're not on as much anticoagulation. And so the overall issues related to this cardiovascular deaths could be lower. However, the interesting limitation here is there were more patients that actually died early on, and then the number of patients who actually had a 5-year follow-up was slightly lower in the Watchman device. So they kind of all compensate for that. So those would be, I would say, the major findings of that. So a dual seal closure mechanism device closes the appendages a lot more effectively with lesser risk of peri-device leaks and has a significantly lower incidence of fatal disabling strokes and overall cardiovascular mortality.
Thank you so much for that insightful comments. Let me ask you another question that comes up in terms of clinical follow-up of these patients with PDL, which is peri-device leaks. Irrespective of when they are found, based on their characteristics, one of the clinical decision points that comes up is to continue anticoagulation, which of course, is put in the context of pre-existing reasons and other reasons for anticoagulation in these patients. So are you able to give our readership and our clinicians a sort of a quick overview of what was learned from this trial and what we should be on the lookout for in terms of anticoagulation um, after getting a device, either due to the device or perhaps due to other reasons why the patient should be anticoagulated?
It's a very good question, Shiv, because it's one of the sort of the Achilles heels of an endocardial closure device, right? So a peri-device leak of more than 5 millimeters was initially considered to be significant. But then as we learned more and more about this, and in fact, we have the Kansas City peri-device leak classification where we call anything more than 5 as severe, 3 to 5 as moderate, 1 to 3 as mild, and less than 1, I mean, it's considered to be a negligible leak. So anytime you have leaks that are more than 5, even though the early limited data from the Watchman trial showed that they have no relevance, but the subsequent evaluation in much larger cohorts clearly showed that they are responsible for increased strokes and increased morbidity. So now the trend has shifted towards using a 3 millimeter leak as a cutoff. When you see somebody with 3 millimeter leak and more, you are more likely to anticoagulate these patients because the risk of strokes is not trivial. And so there is also other interventions like leak closures and all that happen in these patients. And so when we really define what would be that critical threshold that should enable us or should make us think about resumption of anticoagulation even after closure of these appendages, I think is an important one. Above and beyond the peri-device leaks, I think a lot of patient-specific factors and their individual thrombogenicity and the thrombogenic milieu that exists inside the left atrium is equally important. And I think that is an unanswered question at this point in time, why some patients with a completely closed appendage can still form a device-related thrombus, and why some patients with a completely closed appendage can still have a stroke or an embolic event, even in the absence of a device-related thrombus, is still a puzzling question that still need to be answered. So I think as our understanding of the appendage or atrial fibrillation-related stroke risk gets better, we may come up with individualized therapies where in some specific patient subgroups, in addition to the appendage closure, they may need to be an oral anticoagulant, either a full dose or half a dose, really balancing out this individual risks of bleeding and stroke, I think is a field that will continue to evolve. And what makes it even more exciting is the arrival of the factor 11 inhibitors, I think is really going to change this field a lot more significantly.
Thank you for that, DJ. And for our readership, it's the paper from Dr. Lakkireddy's group is going to be accompanied by an editorial written by Drs. Friedman and Freeman, in which they, of course, have sort of graphed out for us what happens with ischemic stroke events for 100 patient years, plotted on the y-axis, when the x-axis is a plot of the CHA2DS2 scores. And what it's very interesting to see is consistently left atrial appendage occlusion devices are here to stay. Technology is only going to get better. And again, it's a great moment that the investigators have persisted. And what matters to us is to bring forth and publish these long-term follow-up data sets. So I would also like to sort of conclude with one additional slide, and that is I'd like to thank Dr. Lakkireddy and his team for having written an extremely comprehensive review on left atrial appendage occlusion devices, which really puts all the current studies in perspective, which is now in press in JACC Clinical Electrophysiology. So thanks for that, DJ. And of course, if you wanted to make any last comments, I put up the central illustration of the review paper.
Thank you, Shiv, for showing this state of the art. And I really appreciate the team for all the hard work that went into it. I think the left atrial appendage closure space is an incredibly dynamic one. There are many things that we learned about what works and what doesn't work. I think two important problems that still need to be addressed is the issue of the peri-device leak and the issue of the device-related thrombus. And then this everlasting debate between which device for whom and why and how, I think is something that's going to evolve. So I say stay tuned. We're going to learn more things. There are a lot more new exciting tools that are coming in our way. So I think the space is only going to get better.